Bismillahir Rahmanir Rahim. Wassalatu wassalamu ala Rasulillah. I'd like to welcome you all to our Webima series. Our Webima tonight for CME, hosted by the Islamic Medical Association of South Africa and sponsored by Bayers. We've got an interesting speaker lined up today, Dr. Andrew Raymond, and he's going to talk to us about the role of antacids in the treatment of reflux. First of all, I'd like to say a few words of encouragement. You know, we've been going through quite a trying time. A lot of our work has moved to online. A lot of our roles as service providers has moved towards providing advice as opposed to just treating patients in a therapeutic relationship, whether advice is informal or in a formal environment, whether the advice has got to be to patients, to colleagues, or in many cases to other community leaders, whether it be the CPF or whether it be your alims in the masjid. And I thought we'd first talk a little bit about the sort of etiquette and the adab, or the respect and etiquette involved in if somebody asks you for advice, how should you approach this advice? Should you just blurt it out, or what should be the way of thinking? And I put together a small little a couple of bullet points, just to say that this is how, if somebody asks us for advice, this is how we respond. Um, I think the is 9 points, and I think when somebody asks you for advice, the starting point should be, the first thing is purify your intention. إنما الأعمال بالنيات. So all actions are judged by the intentions. So purify your intention. Why am I giving this person advice? Is it because I want to impress him? Is it because I want him to agree with my opinion? Is it because I have some kind of material benefit from giving me advice? And based on that intention, you sort of should tailor your advice, and you should temper your advice also. I think the second thing that we should talk about is make sure you have the knowledge. So you're starting with a proper knowledge base. You're not just giving advice based on opinion, unverified opinion, or unverified evidence, or in a field that you are not qualified to give advice in, because giving false information can lead to false outcomes. And I mean, we go back to purifying your intention. The third important point to remember is that of privacy. Besides doctor-patient confidentiality and the POPIA Act, I think common human decency is that if a person comes to you for advice, he's coming from a layer of weakness, and he respects your opinion, and he's coming there knowing that. So it makes no sense to give somebody advice in a public environment about a private detail and without the explicit permission of that person revealing intimate details. And I think when we give advice, gentleness should be also a key aspect, because if you come and you shove your opinion down somebody's throat with no way of speaking, no etiquette, no adab, that person is very unlikely to take your advice. And the whole point of the exercise will be wasted. And coupled with the gentleness is asking permission before you give advice. There's no use being the third wheel in the conversation and hearing two people talking and butting in and saying, listen, I know a lot about the subject, and this is my opinion. You know, I think that's very, very important. I mean, opinions have been compared to a lot of parts of the human anatomy, and which we all have, and not everybody wants to hear it. So I think, or see it. So I think it's very, very important that you ask permission before you want to volunteer advice. And also listen first to what the person is asking. Sometimes if the person doesn't complete his question properly, and we are already giving him advice on how to treat it, or where to get it, or what to do with it. And coupled with that, listening first to the person gives you a means of assessing that person's capacity and try to give that person advice on their level of capacity. There's no use talking to a person who's got a PhD and you're talking to him like he is in standard 8 or whatever the case is. And in the meantime, he could have written the book on the advice that you're giving him. And more, very, 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 very important, I think, is to not be judgmental. I think there's an assumption of trust, And there's some assumption that when a person asks you for advice, it's because that person assumes that they're in a safe environment and a safe space where they can ask for advice without being judged or spoken down to. And I think one of the most important aspects and the final aspect is then leading by example. So it's no use telling a person to whatever exercise regularly and you're laying on the couch while he's busy running past your front door. So I think those are the 9 points on so just a little bit of pointers on how to give advice. They just to recap then, is to purify your intention, to have knowledge of the subject you're talking on, to ensure privacy, to give advice in a gentle manner, to ask permission, to listen to the person first, to assess the person's capacity, not to be judgmental, and to lead by advice. For those of you just joining us, some housekeeping. The Webima is hosted by the Islamic Medical Society of Islamic Medical Association of South Africa, and we'd expect you to have decorum at all times, be polite, make sure that your mics are muted at all times. Unfortunately, because we are sitting in a different environment where there's lots of load shedding, a lot of the people's cameras are not going to be on. I'm not going to put my camera on. Also, we come to you from a very dark Benoni today, and I'm sure many of you sitting in the meeting are also experiencing load shedding. We apologize in advance if there are any technical issues, if there are any dropouts. It might be because the equipment is switching on and off. Feel free to post your questions in the chat box, any comments in the chat box, any suggestions. You can put it in the chat box, or you can then communicate with Sister Kashifa from the Islamic Medical Association directly. The program is CPD accredited. And they will pick up your emails from the meeting, and it will be communicated that way. So without delaying your time more, I know we're sitting here, we've got an interesting talk tonight. It's on something which ESCOM has been giving us a lot of. We're getting a lot of heartburn and stomach ulcers and worry, and I think it's a perfect time of the year. People are stressing about, parents are stressing about kids' exams, kids are stressing about the exams themselves, students are stressing about the exams coming up, and we're all stressing about the tax man. So let me introduce our speaker. We are very, very pleased to have Dr. Andrew Raymond in our presence. He is the medical manager at Merck, and he's got quite an extensive CV. But I think the standout for me, Andrew, if you don't mind me going into it a little bit, is that he's got a very, very severe PhD in physiology, and in particular in cardiovascular physiology. And that might resonate with a lot of our people here, because number one, it's difficult. Number two, it's extremely interesting. And number three, there are so many intricacies of the cardiovascular system, which we feel always lead us back to our creator. So I think that's also a third aspect of it. You know, the heart is always close to people's minds, and whether it's in a spiritual sense, whether it's in a physical sense. So I think the Andrew's PhD resonates a lot with us. Andrew is responsible from Merck's side in interacting a lot with the healthcare systems as a whole, and then to give advice to the industry, to the experts in the industry, in developing systems and products. So he's got quite extensive experience in this field, and he's going to talk to us today about the role of antacids. Andrew?
Hi, thank you very much for that kind introduction. And just a quick thank you for those words of encouragement, as well as to the organizers for making this platform available today for this talk. And then most importantly, I think just to the attendees, right? You know, for making time today, especially during these precious hours of electricity. So I hope wherever you are, it's well lit. So I will start sharing my screen for the presentation. Please just let me know when you can see it.
Andrew, we good? We can see your screen.
Okay, great. All right, so, you know, I think like the introduction said, you know, today I'm just going to give you a brief talk about basically reflux, and specifically, you know, the role that antacids play in the management of reflux, right? So without further ado, right, we're going to get into it. So, first of all, we're going to start with a little bit of information about prevalence of reflux. So, unfortunately, we don't have enough data to establish what our local prevalence is. But there is this study that was done in 2020 that basically examined what the global prevalence of gastroesophageal reflux is, right? So they estimate that this was approximately 13.98%, right? Which they basically estimated to 1.03 billion individuals across the world that are currently affected by reflux disease, right? Some other important pieces of information that came out from the study. They found that females have a slightly higher risk versus males in terms of the prevalence of reflux. They noticed the highest prevalence was in individuals that had a BMI of greater than or equal to 30. Okay, and they also noted that these individuals is also correlation between, the reflux disorder and individuals with high intake of fatty foods as well as carbonated drinks, right? And lastly, they also noticed that the prevalence was higher in those with moderate to high intake of tea and coffee. Okay, so looking at some of the local data that we do have available. So this slide shows, some of the results from a study looking at the burden of illness in patients with reflux disease in South Africa. So this graph on the left basically shows the results from a short form health questionnaire, which is basically an extensively used generic health-related quality of life questionnaire, right? So the gray bars basically show you the results of the patients who were experiencing reflux, and this black line represents normal values, right? So we don't have any normal values established for South Africa. So this paper used UK normal values, and basically how you interpret this is that any score that's less than 5 points of the normal values is something that you can consider clinically relevant, right? So we can see across the board in terms of quality of life, there is declines in quality of life in terms of physical functioning, bodily pain, general health, vitality, social functioning, as well as mental health, right? In these patients who are experiencing reflux, okay? If we look at the table on the right-hand side, right? This study also examined if there were any correlations, right, between specific gastric symptoms and as well as these, quality of life measures using a specific, reflux and dyspepsia questionnaire, right? So what they did find, there was very strong negative correlation between the gastric, symptoms such as reflux, abdominal pain, indigestion, diarrhea, constipation, with all domains of this reflux and dyspepsia related questionnaire, right? So the reflux, so the gastro symptoms were negatively associated with emotional distress, food and drink problems, physical and social functioning, sleep disturbances, as well as vitality, right? And they did also find some, statistically significant negative correlations between these gastric symptoms as well as the short form questionnaire results as well, right? So, basically the take-home message from this is basically, that, reflux is not necessarily a condition we attribute a high amount of mortality and morbidity with, but it nevertheless still has a high impact on the quality of life of people who do experience, this disorder. Okay, so moving on to some of the key anatomical and physiological factors involved in reflux. All right, so this figure on the left, right, basically shows you the junction between your esophagus and your stomach, right? And primarily, this is separated by your lower esophageal sphincter, which basically forms a barrier between your esophagus and your stomach, right? So generally speaking, when we're talking about reflux, it tends to occur whenever your gastric contents leak out from your stomach into your esophagus, and they cause those classical signs and symptoms of reflux, like the heartburn and the epigastric pain, right? So on the right-hand side is basically just an illustration of your stomach, with as 4 key layers, right? So you've got a mucosal layer, which consists of your gastric glands. You've got a submucosa, which contains your blood vessels, a muscle layer, and your final layer of connective tissue called the serosa. Right, so looking at the gastric glands in a little bit more detail, right? So your gastric glands are lined with 4 specialized cells. You've got surface mucus cells, and basically their role is to produce mucus as well as bicarbonate, which basically helps form a protective barrier, right? Protecting your gastric mucosa against the harsh acidic environment of the stomach, right? And then further within the gastric glands, right, you've got very specialized cells, right? So you've got your parietal cells, which is represented by this, this blue image on the right over here. And basically your parietal cells are responsible for the production of hydrochloric acid, right? So your parietal cells contain your hydrogen potassium ATPase protein channel. So this is what's commonly referred to as your proton pump, right? So this channel basically exchanges hydrogen with potassium, right? So it'll, excrete hydrogen into the lumen of your of the gastric glands, right, into your stomach, right, and exchange that for potassium, right? And then your potassium and chloride will then be exchanged via your proton gradient, right? So the net effect is basically your parietal cells release hydrogen and chloride ions, which then form hydrochloric acid, right? It's your stomach acid, okay? You've also got your chief cells. So your chief cells play an important role in terms of producing pepsinogen, right? So pepsinogen, once it's released into your stomach, forms pepsin, which is an important enzyme involved in the breakdown of proteins, right? And the key thing about pepsin is that it's only activated in very low pHs, right? Which also helps protect, your cells from being degraded, by this pepsin inappropriately, okay? And you've got your neuroendocrine cells, okay? So you've got your G cells, which produce gastrin, right? So gastrin basically promotes the production of stomach acid. It does this via 2 mechanisms, right? So gastrin can either directly stimulate your parietal cells to produce hydrochloric acid, right? Or it can stimulate your enterochromaffin cells, right, to produce histamine, right? Histamine then binds into the receptors on the parietal cells, and then the net result there is also the production of hydrochloric acid, so stomach acid. Okay, you want your D cell, right? So your D cell basically produces somatostatin, right? Which basically has the the opposite functions of gastrin, right? So it works on the parietal cells to inhibit the production of acid, right? And it also inhibits your enterochromaffin cells to decrease and inhibit the release of histamine. Okay, so basically, somatostatin is produced when your stomach acid becomes too low, right? So, and then gastrin basically is stimulated when your pH is getting high, right? So those 2 hormones are key in terms of the negative feedback loop, keeping your pH levels in balance, right? But gastrin is also produced by distension of your stomach, and also by the presence of amino acids in your stomach, right? And then lastly, you've got your enteric nervous system, right? So your vagus nerve. It can also directly stimulate the parietal cells to produce hydrochloric acid, as well as on your enterochromaffin cells, as well as on the D cells to produce somatostatin, right? So I think some important considerations when you're looking at the pharmacology of acid suppressive drugs. So when you're looking at your H2 receptor antagonists, right? They basically only work on this avenue over here, right? So they bind onto this histamine receptor and basically block acid production via this one mechanism, right? But you can see there's 3 other mechanisms by which your parietal cells can be stimulated to produce acid as well, right? So when we're talking about proton pump inhibitors, they work directly on those channels themselves, right? So proton pump inhibitors basically work by inhibiting every single release of acid while your H2 receptor antagonists only work on one specific pathway over here, right? So just a little bit of background information in terms of how, stomach acid is regulated. Okay, so I think another important feature, in addition to basically the neuroendocrine regulation of stomach acid, is a phenomenon known as the acid pocket, right? So the acid pocket is it's a physiological phenomenon, basically, that occurs in all individuals, and what it is a region just below the lower esophageal sphincter, which is more acidic than both the esophagus and the upper portion of the stomach. Right. So the investigators who first noted this phenomenon, they described it as a pocket of acid floating on top of the ingested meal. Right. Right. So this acid pocket is most likely caused by gastric acid, right, that hasn't mixed properly with food, and as such, basically floats on top of your ingested food and has a much lower pH. Okay. So I think the concept of this acid pocket is quite important because it addresses the paradox of that was previously present in the fact that most heartburn episodes occur postprandial, right? But obviously postprandial is when your stomach pH is at its highest, right? So basically that acid pocket is basically the one responsible for these signs and symptoms of heartburn. Okay, when we're talking about the pathologies of your stomach, right? You can sort of split them into three broad categories. You've got anatomical pathologies, ulcerative pathologies, as well as inflammatory conditions. You also do have cancers as well, and other, more obscure pathologies as well. But looking at some of the key examples of anatomical pathologies, one of these is hypertrophic pyloric stenosis, right, which is basically hyperplasia of the muscle layers and the mucosal wall of the pylorus. Right, you've got your ulcerative pathologies, so you've got your peptic ulcer disease, which is a breakdown of the mucosa and submucosa of the stomach lining. You've got your gastroesophageal reflux disease, so reflux of gastric acid into the esophagus. Dyspepsia, which basically incorporates a lot of the symptoms of indigestion, right? And there is a large degree of overlap between the signs and symptoms of dyspepsia and gastroesophageal reflux disease. Okay. But from a clinical point of view, to try and differentiate these two conditions, what the American College of Gastroenterology is defined dyspepsia as predominant epigastric pain lasting at least 1 month, right? But nevertheless, there's still a large degree of overlap between GERD and dyspepsia, right? But for the remainder of this talk, we'll primarily be focusing on the reflux disease, okay? Then you've got your inflammatory conditions, so your inflammatory bowel diseases such as Crohn's disease, gastritis, inflammation of the gastric mucosa, as well as your H. pylori gastritis, right? Okay, so looking at gastroesophageal reflux disease in a bit more detail, if we're looking for a hard definition, basically from the Montreal Consensus, it's defined as a condition which develops when the reflux of stomach contents causes troublesome symptoms and no complications, right? And in terms of your symptoms, your profile, you've got your typical and your atypical symptoms, right? So your typical symptoms are heartburn, occurring either during the daytime or the nighttime, regurgitation, daytime or nighttime, and water brush or hypersalivation, okay? So those are your typical symptoms of GERD, right? We're talking about the atypical symptoms. We're talking about nausea or eructation, which is just a burping or belching, slow digestion, early satiety, so you feel full very quickly, epigastric pain, bloating, and the key thing with these symptoms is that if they can be considered related to GERD, if the symptoms respond in terms to PPI treatment as well, right? So that's an important consideration. I think you've also got vomiting, chest pain, respiratory symptoms, right, which include coughing, wheezing, chronic rhinosinusitis, your ENT symptoms as well, hoarseness, pharyngeal pain, and globus. Right, in terms of some of the risk factors associated with gastroesophageal reflux disease, you've got your eating and lifestyle risk factors. So it's more prevalent in individuals who gain weight, people who have a high body mass index, people with a high intake of dietary fats, carbonated drinks. So in terms of coffee, there are strong associations between coffee and reflux. The mechanism is pretty unclear. It seems to be more related to the caffeine than the coffee itself, right? Nevertheless, that association is present. And likewise with smoking and alcohol, right? So the associations are there. The underlying mechanisms haven't fully been fleshed out, but they do know it's associated with increased risks of malignancies, right? With these two factors, okay? You've also got medications, right? So treatment of comorbidities with calcium channel blockers, anticholinergics, NSAIDs, may affect GERD and the treatment thereof, right? Also potassium supplements, tetracycline, bisphosphonates, they can also cause damage, right, to your upper gastrointestinal tract, right? And then pregnancy is also a known risk factor associated with reflux, right? So the presentation doesn't necessarily differ from the general population, right? But it does tend to get worse as the pregnancy advances, right? Regurgitation also occurs as the same frequency with reflux. And the factors that increase risk in people who are pregnant with heartburn are those who have, heartburn prior to pregnancy, the number of previous pregnancies, as well as the duration of pregnancy as well, right? So, looking at some of the pathophysiology of, reflux disease, it's a little bit, multifactorial, right? There's a lot of complex components related to it, and I think, it's still very much in the learning phases to fully understand all of the, factors associated with, the signs and symptoms related to reflux. Okay, but I mean, so from this, the review paper that I found, they basically classified it into two factors in terms of, the physiological factors that are actually causing the reflux, right? And then factors that also affect, the patient's perception of the symptoms, right? So when you look at the physiological factors, obviously one of the biggest ones is the hiatus hernia, right? Associated with reflux disorders, lower esophageal sphincter pressure, right? So that barrier between your esophagus and your stomach, right? There's several factors that can cause this. So hiatus hernia can cause it, medications can cause it, certain foods can, hormones as well, right? Can have a negative impact on your lower esophageal sphincter, right? You've also got transient lower esophageal sphincter relaxation, right? So, that sphincter, will time to time relax at inappropriate times, allowing your gastric contents to reflux from the stomach to the esophagus. We've got your acid pocket, which we discussed briefly previously. Obesity, increased ostensibility of your esophagastric junction, right? So you've also got between your esophagus and your stomach, network of ligaments, smooth muscles, and these can also be affected by a whole host of factors, which basically can promote reflux, right? If there's, your clearance of your esophagus is prolonged, that can be a risk factor for reflux, as well as delayed gastric emptying, right? So those are sort of what you consider the physiological factors, right? And you also got, the factors that affect, how severe or your perception of those particular symptoms, right? So the first one is basically, the acidity of the reflux. Okay, so the proximal extent, which basically means, where exactly along the esophagus, the reflux is, targeting or occurring. The presence of gas in the reflux, right? Because gas can also cause, distension of the esophagus, which can also cause, pain and some of the signs and symptoms of reflux, right? Then you've got duodenal, gastroesophageal reflux, right? So this basically refers to, the other components other than just the acid, which can have a negative impact on your sort of esophagus and the mucosa, right? So we're talking about bile, trypsin, as well as pepsin, right? Which can all have a noxious effect on your mucosa, right? You've got longitudinal muscle contractions along your esophagus, right? So they have shown that there's strong associations between episodes of reflux symptoms and these contractions of these muscles present in your esophagus. Your mucosal integrity can have an impact, and then lastly, peripheral and central sensitization, right? So that can cause, hypersensitivity to any sort of injury that might be occurring in your esophagus, right? So, changes or damages to those nerve endings present in your esophagus, can cause hypersensitivity, and worsening, of these symptoms. Okay, so, now I'm going to take a look at, the management of reflux diseases, right? So these recommendations are coming from the World Gastroenterology Organization, right, which have taken, a consensus from a lot of the, global organizations across the world in terms of their recommendations, and they've consolidated quite nicely into, one document that incorporates, a lot of these inputs from the different gastroenterology organizations across the globe, right? So when we're talking, for the range of this talk, I'll be splitting it basically into two categories, right? So infrequent heartburn, which is, less than 2 episodes per week. And then later we'll talk about the management of, more, when there's more symptoms or more episodes in a given week, right? So, firstly, when we're talking about infrequent heartburn, right? The recommendations are first, always lifestyle modification, right? So weight loss, right? So controlled weight reduction, can help reduce the frequency and the intensity of symptoms, and can also lessen the grade of the, of the erosion present in your esophagus as well, right? From a lifestyle point of view, right, the recommendations are to avoid few foods that trigger the symptoms, right? So they recommend having small meals, avoid having meals, late at night or, within 2 hours before going to bed. And they also recommend, having a look at your sleeping position, right? So, gravity is one of the biggest things helping you avoid reflux. So, if you're having, a lot of nocturnal symptoms, one of the advice that you can do is basically to sleep with your head elevated, right? Which can help with those nocturnal episodes of heartburn, right? And then also, OTC medicines, right? So antacids or alginates, right? So they offer, the most rapid symptom relief, right? But this relief is transient, and generally speaking, they're unlikely to have, any serious adverse, side effects when we're talking about these OTC medications. Okay, so going into antacids, firstly, in a bit more detail, right? So these have been around for, a very long time, okay? They're basically inorganic compounds that help neutralize acids, okay? In terms of, their efficacy, calcium carbonate is the antacid with the strongest acid neutralizing potential, followed by sodium bicarbonate, and then your magnesium and your aluminium salts, okay? All right, so I'm primarily going to focus on, the calcium and the sodium, antacids for this talk. I think, a lot of the antacid, available on the market are combinations, but these are the two primary ones, and the other ones tend to have, secondary or, other, functions within the formulation itself, right? So we look at, the mechanism of action of what these antacids are actually doing, right? So we're talking about calcium carbonate, right? When it comes into contact with hydrochloric acid, you basically produce calcium chloride as well as water and carbon dioxide, right? So basically this calcium carbonate helps to neutralize this acid by producing, these salts as well as water and carbon dioxide, right? When we look at, sodium bicarbonate, when it comes into contact with hydrochloric acid, your byproducts are, sodium chloride, which is basically table salt, as well as water and carbon dioxide, right? So generally speaking, we're talking about the mechanism of action, right? Antacids work to, raise your pH, almost immediately, right? Or, as long as it takes to basically travel from your mouth down to your esophagus, right? So the duration of action, can be up to 3 hours if you take it with your meal, or 1 hour if you take it postprandial, and then about 20 to 60 minutes if you take it on an empty stomach, right? Another important feature of antacids is that basically they raise the pH of your gastric contents, which help inhibit pepsin activity, right? So like we mentioned previously, pepsin is one of those, those enzymes that can basically help, or degrade the mucosa, and worsen the signs and symptoms of reflux. Okay. Just want to pause there for a second. Does anybody know how I get rid of these drawings on the screen? I'm going to stop sharing for a minute and then reshare. Hopefully that goes away. Okay, good. Can everybody see the presentation?
Yeah, it's perfect, Andrew. Thanks.
Cool. All right. All right. So looking at some of the recent data we have available, demonstrating basically the efficacy of antacids. Right. We've got this study here, which was an in vitro investigation using a well-validated model of the human gastrointestinal tract. Right. On the left-hand side over here, on these figures, you've basically got a representation of pH over time, right? The orange bar was, the test product in this particular investigation, which was 780 milligrams of calcium carbonate and 80 milligrams of magnesium carbonate. And this was compared to a control of placebo, right? So this was during the first 5 minutes of the study. And what you can see that there was a rapid, increase in pH once the test product was actually introduced into this experimental model of the human GIT, right? So basically, what you can see is that under a minute, your pH was increased to greater than 3, right? So when you're looking at these type of studies, when you're looking at the efficacy of antacids, your base threshold, target of pH to measure efficacy is anything greater than 3, right? So basically, in approximately 40 seconds, the product managed to increase the pH above 3, right? So this was during the first 5 minutes of the investigation, right? And the figure on the bottom over here shows you the profile over the 2-hour period, right? So again, when you're looking at that threshold value of about 3, right, it was also able to maintain this pH for about 56 minutes, right? So again, this is basically just highlighting the fact that antacids work very rapidly, right? So they tend to work within seconds once they've been introduced, right? And then the second aspect of this study investigated was the activity of pepsin, right? So if we look at this figure on the bottom right-hand side over here, which basically which was tracking your pepsin activity over the 2-hour period again, what you can see is with the calcium carbonate product is that the activity of pepsin was reduced, right? With that initial hour period where the pH was increased, right? So again, showing you that that pH induced inhibition of pepsin can also have positive effects on the signs and symptoms you see in reflux. Okay, so just thinking about some of the things you need to take into consideration when using these two popular antacids. From the calcium carbonate point of view, like we mentioned previously, the byproducts are calcium chloride, carbon dioxide, and water, right? So 90% of this calcium chloride is converted into insoluble salts, which are basically passed with your stools and not absorbed, right? The remainder of that is pretty much absorbed and excreted, rapidly through your kidneys. And so some of the side effects of calcium carbonate-based products is constipation, right? And the constipation is offset, generally speaking, with the inclusion of magnesium salts, right? So magnesium salts tend to have a laxative effect, which sort of counter affects that, right? Then you've got belching and flatulence, which is, basically as a consequence of that carbon dioxide, right, that's being produced. So in terms of contraindications and warnings, right, you don't want to use this in severe renal insufficiency, right, because it can cause an accumulation of those calcium chloride ions, right? You don't want to use it in scenarios where there's hypocalcemia, as well as kidney stones due to calcium-containing deposits, right? Stop sharing again, just to get rid of those annotations. Right, then from sodium bicarbonate, like I mentioned, the byproducts of sodium chloride, which is table salts, right? Carbon dioxide and water, so the problem with these, antacids is that they do contain quite a high sodium load, right? So I think, some of the products do, give you more than 50% of your, daily recommended allowance in one single dose, right? So if you can avoid it, I think, there are alternative options available that don't have this negative impact on your sodium load, right? It can cause gastric distension, belching, and flatulence, right? And like with the calcium-based products, right, you shouldn't be used in moderate or severe renal insufficiency, and then anybody who's trying to maintain like a low salt diet, right? So hypertension, cases of congestive heart failure, and renal impairment as well. I also want to touch on, some of the drug interactions that are present with antacids, just to make you aware that that's something does need to be taken into consideration. While they are generally safe, they don't tend to have a lot of side effects. They can tend to have some drug interactions, right? So, the three mechanisms primarily involved in the drug interactions are, the antacids binding to another drug in the GIT, or changes due to the gastrointestinal pH, as well as changes to the urine pH. Right, so this is not an exhaustive list. I've basically just taken this list just to highlight that it's something to take into consideration. I think, it is something you probably have to, just make sure you're aware of for the particular products that you're suggesting to your patients, right? So, you've got decreased activity with allopurinol, right? So sodium bicarbonate can prolong the effects of amphetamines. Generally speaking, antacids can increase the rates of absorption of enteric-coated aspirin. Calcium-containing antacids can decrease the bioavailability and prolong the half-life of atenolol. You can have the decreased absorption of corticosteroids, right? Increased half-life of erythromycin, decreased bioavailability of ketoconazole, right? Sodium bicarbonate can decrease the serum concentrations of lithium, right? Decreased effects with sodium bicarb on methotrexate. And some antacids can also cause decreased absorption of tetracycline. Right, and the next thing I want to talk about is, alginates. So, generally speaking, these aren't antacids, but, they are basically alginate antacid combination products that are available on the market, right? So you've got the primarily sodium alginate in these products, which is derived from seaweed, okay? So this sodium alginate interacts with gastric acid to basically form a strong buoyant raft, right? So if you look at the chemical reaction that's actually taking place, right? So within this acidic environment of the stomach, the sodium alginate forms basically algicinic acid, which is basically a viscous gel, right? And the byproduct of this is also carbon dioxide, right? So what happens is these carbon dioxide bubbles contract within this, algicinic acid, and basically forms this floating barrier, right? Which basically sits on the top of your stomach. And what it does, importantly, is help displace that acid pocket, right? So, when you're thinking about alginate, their mode of action is primarily physical, as opposed to, pharmacological. They form a physical barrier, preventing, stomach acid refluxing back up into the esophagus, right? They help displace that acid pocket, right? So it doesn't cause signs of reflux, right? They can also inhibit pepsin by, binding directly to it and inhibiting it. And there's also some evidence to suggest that there's also topical prevention that you might get from alginates as well, right? So they can bind directly to the mucosa of your esophagus as well. Right, so looking at some of the data available for alginates, right? This study basically was looking at the efficacy of a calcium carbonate and magnesium carbonate with sodium alginate, combination versus a sodium bicarb alginate combination, right? So the study had two arms where they looked at the efficacy in vitro, right? And they also did a in vivo investigation in healthy volunteers as well, right? So in terms of the efficacy, looking at the figure on the left, right? So your black line shows you the sodium alginate, the calcium carbonate, as well as the magnesium carbonate antacid combination, right? And the dotted line is showing you the sodium alginate plus sodium bicarb plus calcium carbonate in this specific example, right? So you can see this combination produced, two things that were very important, right? So one, it had a much higher acid neutralizing capacity compared to the sodium bicarbonate based liquid. Okay, so you can look at your neutralizing capacity measured in millimoles of hydrogen, right? So this calcium carbonate based alginate formula had a capacity of 31 millimoles of hydrogen compared to 8.1. Okay, and the other important thing at the time, right? So the time that the baseline pH of greater than 2.5 was achieved was 130 minutes compared to 16 minutes, right? And the primary reason for this is this specific formulation has a very high antacid content, right? Compared to this the sodium bicarb formulation, right? Which is important results because historically, the thinking was that, if you had a high content of antacids mixed with your alginate, you wouldn't get that CO2 production and you basically wouldn't get a buoyant raft forming, right? But these results show that you can basically include, right, a high dose of antacid plus sodium alginate to form a really strong raft that offers you both, effective acid neutralization over a longer period of time, right? Compared to a, conventional low antacid sodium alginate, combination, right? So, and these basically translated well when they looked at, the human, volunteers as well, right? So what they did over here is that they took healthy volunteers, they put electrodes down through their nose into the esophagogastric junction, right, and measured their their pH readings over a given period of time, right? So the comparators here was this calcium carbonate alginate versus placebo, right? So you can see the onset of action in this in vivo study was about 4.1 minutes, measured by assessing the time lag to reach a pH of 3, right? And the other important finding is that the duration of which the pH was greater than baseline was about 87 minutes, right? So over an hour, right? So I think these are quite key findings in terms of demonstrating the fact that you can have an alginate which provides that physical barrier against reflux going into the esophagus, in combination with an antacid that can also provide acid neutralizing capabilities on top of that as well, right? So working on two mechanisms at once. Okay, so the previous discussions have been focused around how you sort of manage things with infrequent episodes of heartburn, right? So less than 2 episodes per week, right? And this is basically outlining the recommendations again from the World Gastroenterology Organization for patients who have more frequent symptoms, right? So for patients who have more frequent symptoms, the recommendation is basically they need to be assessed for longer term therapies, right? So, a diagnosis of GERD, which is basically troublesome symptoms 2 or more times per week, right? So the recommendation is that it warrants, therapy with an antacid inhibitor. Right, so these are basically your proton pump inhibitors, or if available, your H2 receptor antagonists. Right. What they also recommend is that your antacids and your alginates, right, should also be used if PPIs or H2 receptor antagonists are unavailable, right, or if the patient needs prompt symptom relief, right. So that's the recommendation on how antacids fit in, those patients who are basically on long-term therapy, right? And then some, more general guidelines in terms of how to manage patients with long-term therapy, right? So the recommendations are to, one, use the lowest effective dose, which I think is, basically common to all medications you prescribe, right? You want to use the lowest dose capable of providing acceptable symptom relief, right? For those patients with mild symptoms, you want to sort of take self-directed approaches or intermittent PPI therapy, so on-demand therapy might be useful so long as the symptom relief still remains adequate, but it can be a more practical, more cost-effective way of managing things long-term. Right, so they recommend using combinations of alginates and antacids along with the acid suppressive therapies, right? And the recommendation for that is because obviously, they may be more beneficial in terms of providing symptom relief than acid suppressive therapy alone, right? And there is data to support that shows, symptom relief tends to be higher in people using, antacid alginate combinations with PPIs in combination, right? Another important thing is patient education on how to use PPIs properly, right? So, it's very important these are taken basically at a meal time, right? So, you want to take a PPI 30 to 60 minutes before breakfast, right? And in case twice a day dosing, if you try, if you need to take that step up approach, 30 to 60 minutes before the last meal of the day as well, right? So I think patient education there and how to use drugs properly, right? So these basically aren't as effective if you don't time them according to your meal times, right? In terms of treatment failures with PPIs at full dose, they recommend to trial a step-up therapy to twice daily PPIs, right? And for PPI refractory patients, the recommendations that for some patients twice daily may not work, right? Because the symptoms may not be related to the acid reflux, right? Or the degree of acid reflux is not necessarily sufficient to provide symptom relief, and in these cases, you want to refer to secondary care, right? Okay, we're going to finish off with some special populations. I touched on it a bit earlier, right? We're talking about treatment of reflux in pregnancy. So there's primarily hormonal and mechanical factors involved in pathophysiology here, right? So during the first trimester and as the gestation progresses, the lower esophageal sphincter pressure gradually falls to anywhere between the 33 to 50% of normal values, and it basically reaches a low point at about 36 weeks of gestation, right? And the primary driving factor in that decrease in lower esophageal pressure are your increased concentrations of estrogen and progesterone, right? Some two potential mechanisms as well, but yet to be confirmed, is that the rise in intra-abdominal pressure due to the gravid uterus, right? And potentially as well abnormal gastric emptying or delayed small bowel transit. Right, so this is the treatment algorithm from the World Gastrointestinal Organization, GAIN, right? So, they regularly recommend, a step-up approach to it. So they start with, dietary and lifestyle modifications. So more frequent meals, small meals, right? And basically to take your last meal at least 3 hours before bedtime and to elevate your head, right? The next step up is, antacids, right? So you want to avoid the long-term use or high doses of, magnesium silicate, which is not that common. And they also recommend avoiding any antacids with the sodium bicarbonate, right? Because obviously that has, implications on volume overload, right? Because of that production of sodium chloride as a byproduct. Okay, these guidelines are from 2017. So as you can see, they still recommend the use of ranitidine, which is obviously not applicable any longer, right? So unfortunately, there's also very limited data for the use of other H2 receptor antagonists. They do generally consider them to be probably safe. Right, in terms of PPIs, as your next step up, right, if the signs and symptoms are still not resolved, they recommend omeprazole, right? So we're talking about FDA categories of medications you can use in pregnancy. Category B basically relates to a medication that has been shown to be safe in animal studies, but doesn't have any convincing data in terms of human studies, right? So those are the recommendations. But basically, anything past the use of antacids, obviously would be, with the discussion, with the patients and the gynecologist, right? And then, looking at lactation, right? So antacids during lactation generally considered acceptable during the breastfeeding stage, right? So there's no any particular information about aluminium, calcium, or magnesium contents in breast milk while taking antacid therapy. But important things to bear in mind is that magnesium and calcium, are normal components of breast milk, right? So generally, antacids are considered, safe to use. In terms of alginate during lactation, right? So basically these things aren't absorbed, and they're basically absorbed in minute quantities, right? They're not significantly metabolized, and they're also considered to be acceptable during lactation, right? And then lastly, what I wanted to finish off was basically just some of the warning signs, just to consider in terms of differential diagnosis or considerations to when you should refer a patient to a gastroenterologist, right? So none of these all are specific to GERD, right? So they can be related to other pathologies such as cancer, peptic ulcer diseases, or other serious illnesses, right? But we're talking about things such as dysphagia, so pain, so difficulties in swallowing, polydysphagia, which is painful swallowing, recurrent bronchial symptoms, aspiration pneumonia, dysphonia, so changes in your voice, a recurrent or persistent cough, any sort of GI bleeds, frequent nausea or vomiting, persistent pain, iron deficiency anemia, progressive unintentional weight loss, lymphadenopathy, epigastric masses, and then any new onset atypical symptoms at the age of 45 to 50 years of age, right? And also another important note here is when we're talking about, diagnosing GERD, right? So if any of the predominant symptoms or the primary complaint relates to an atypical symptom, that's usually a sign to revert to a specialist as well, right? And if also there's a family history of either esophageal or gastric adenocarcinoma. I think, yeah, that's it from my side. So I think just thank you for your time and attention.
Thank you very much, Andrew, for that comprehensive talk. I think it was not very difficult to swallow, and a lot of us have a stomach for more of the for more questions. So I don't know if you want to go through the chat box, or do you want me to go through the chat box, and we'll address some of the questions. In the meantime, if any of you want to unmute your microphone and perhaps ask a question directly to Andrew, you're also welcome to do so. So Andrew, in the meantime, we've got one question from Deva Mudli, who says, would one then start triple therapy at primary care level?
No, and you wouldn't, because generally speaking, there isn't a recommendation for an antacid and 2 acid suppression drugs, right? So you'd either move on to, for those patients with more frequent symptoms, we move on to, basically full dose of PPIs, and then the addition of the antacids, right, to help with symptom relief as they progress. In terms of other medications, you can't use an H2 receptor antagonist long term. There's also no recommendations regarding, mucoprotective agents, as well as, prokinetics as well. So there's no particular benefits there as well.
All right. The next question is then, what is the risk of iron deficiency with PPI use?
I'm not sure. Right. So I think, with iron deficiency, I'm not sure about the actual percentages, right? It is there, but I don't think it's present to a clinically relevant, considerations, right? So it does tend to happen, but it's not clinically relevant. I'm not sure exactly what the percentages are.
Okay, and I think just a follow-up question from Rashid Nur Mohammed there is that what are the long-term side effects of PPIs, as many patients have become dependent on them?
Yeah, so I think, well, I mean, it wasn't a PPI talk, but in terms of the long-term, side effects of PPIs, I think more and more they're starting to come to light. Obviously, you can get, refractory acid rebound on patients who start, come off long-term PPI therapy. There's increased risks of specifically gastroinfections. I think there's also a bit associations found with PPIs and respiratory infections, although I think the underlying pathophysiology related to that association is something yet to be determined. And I think obviously the iron sort of things. There are, long-term consequences of them, but I think, as always, you have to weigh up, the risks versus the benefits from it.
Mm-hmm. All right, and the next question is then acid reflux in babies causing the infamous colic. Any thoughts on using antacids or any of the other medication in kids and in children, in infants?
No, so antacids no antacid basically indicated for the use anybody under 12 years of age, right? So not an option for babies experiencing colic.
And then the next question is then, when do you scope a patient? So Mohammed Kathara wants to know, would you suggest endoscopy before scripting a PPI? Would you try a trial of PPI first, or how should your thought process be?
Right. So I think, if you haven't had a look at the WGO guidelines, I think I would highly recommend it because they do give a very nice breakdown in terms of, I think, the diagnostic criteria. But generally speaking, when you talk, their recommendations regarding diagnosis for GERD specifically, right? So, one, if it's, frequent symptoms more than 2 times a week, and the primary symptoms are a typical symptom. So the acid reflux, the regurgitation, or the hypersalivation, right? 90% of the time, they say that's sensitive for GERD, right?
Yeah.
So in terms of when you consider sending someone for a scope is when there are atypical signs and symptoms, right? So the table I presented earlier outlining what the atypical symptoms were, or if there's, other sort of gastropathologies that they want to investigate. But generally speaking, the scope wouldn't change the management of the GERD in any way, shape, or form. It's more to sort of investigate other pathologies.
And specifically in terms of the PPI used, in terms of omeprazole versus esomeprazole, there are cost implications there. So I'm not sure, is there any benefit to one over the other?
So in terms of the guidelines, they don't recommend, from an efficacy point of view, right? They don't recommend any particular PPI over the other, right? But I think that it comes down to the individual drug itself, because obviously they will have different drug interactions and things like that. So from an efficacy point of view, the guidelines don't distinguish between the different molecules themselves. I think it then comes down to basically just looking at the individual products and deciding which has the best safety profile or interaction profile for the given patient.
Okay. So, and if you were going to dose, let's say with an antacid and a PPI, what are your thoughts about those taking both at the same time?
Yeah, so I mean, that's something the guidelines do recommend. So obviously I would recommend taking, that combination I showed earlier. So, the dual sodium alginate with the high antacid combination, primarily with calcium carbonate, and then with, for basically the rapid symptom relief, right? And then the long-term maintenance with the PPI.
Okay. And in terms of COVID, Andrew, you found people prescribing the histamine antagonists for COVID as opposed to just for antacid. You found any of your people doing that?
No, I haven't seen any sort of any literature or studies about that. I did see an interesting article related to PPIs in COVID, actually. You know, and basically what they found in this particular paper was that there seems to be an association with worse outcomes using PPIs, right? Primarily because the rationale behind it was that you know, parts of the functions of your the low pH of your gastric juices is to basically destroy pathogens, right? So it has a immunological function, right? So with the reducing the pH, the thinking is that you sort of reduce that first barrier, and you might get worse outcomes in that respect. But I didn't read the article on full details, but I just thought that was interesting. I just wanted to share as well.
Okay. All right. Any other questions from anybody? Cynthia wants to know how many CPD points. Cynthia, I think one of the admins will reply to you directly on the chat, or I'm sure via email. Any other questions related to the role of antacids in reflux disease? You guys could unmute yourselves or put your videos on if you want, and then ask Andrew directly. Okay, so the silence is deafening the Andrew. I suppose it's usually a good sign. If there's not many questions, it means you've done a good job. You've covered the subject comprehensively. Thank you very much. So I think if there's no other questions, we close the meeting. I'd like to thank everybody for coming in and attending, especially taking out your time in these times where you're not sure whether your lights are going to go off. I'd like to thank Andrew for taking his time out, and for Bayer for sponsoring the event. And then once again, we'd like to thank the Islamic Medical Association of South Africa for their Webima series. We've really been looking forward to it at least once a month, every Wednesday evening. Many of you are what you call repeat offenders on the platform, and we really appreciate the fact that you guys are joining us on Wednesday evenings. For those of you that want any more information about the Islamic Medical Association, you can just hit us up at Islamic Medical on Instagram, and you can find all our other links on there. Andrew, once again, thank you very much for joining us. We'll conclude the meeting with والعصر أعوذ بالله من الشيطان الرجيم والعصر إن الإنسان لفي خسر إلا الذين آمنوا وعملوا الصالحات وتواصوا بالحق وتواصوا بالصبر. Just a reminder that we will be having a recording available. Whoever wants to get the recording, those will also be communicated with everybody. Thanks once again, everybody. Good evening.
Thank you. Keep well, everyone.